All right, so we're here for kind of what I would call an extended coffee break in a way. So we're joined here with Cosi from Cosi Talks, who's an amputee specialist herself, really talking about some considerations for bilateral amputees. In our previous Mission Gait videos, we've covered a wide range of topics, but one thing we haven't touched on as much is really the considerations for bilateral amputees. So we're going to talk through a few different points, just to kind of give some ideas and some consideration to folks dealing with bilateral amputations, kind of going through just starting from balance to like getting out in the community. So first of all, thanks, Cosi, if you don't mind sharing a little bit about yourself and kind of what you do in Cosi Talks.
Sure. No, and thank you for having me on board for this. I love working with the Mission Gait organization. So as Will mentioned, my name is Cosi Belloso. I am a physical therapist. I've been a PT now for a little over 18 years, and I have my own practice here in Tampa, Florida that's exclusively for working with the limb loss community. And I'm also the host of Cosi Talks. It's a live show I stream every Wednesday night at 8:30 p.m. Eastern Time. From Facebook and YouTube to answer questions and bring education to the community. So I am excited to be here today. Thank you.
Yeah, and Kosi's been a collaborator. May even recognize your face from some of our Mission Gait videos, our Discover Your Possible video that we did last year. A number of things. We've even been branded. We got the mug right here. So, but let's go ahead and sort of dive into our topics here. So first off, considering somebody who is, maybe undergone a first amputation and sort of adjusted to life as a unilateral amputee. What are some just kind of like immediate considerations, things that, they're thinking about or things that we need to be concerned about as practitioners when working with bilateral amputees?
Well, with the bilateral, it's the statistics are roughly that after a person experiences their first amputation, they have a much higher risk of a second one within 5 years, especially if their first one was due to peripheral vascular disease or, complications from diabetes. So for me, one of the first things I consider is, what was the cause of the amputation? If it is because their diabetes or peripheral vascular disease or whatever was out of control, it's okay. I need to communicate with their medical team and find out, is this finally under control? And definitely finding out what are their limitations, if they have any limitations, if they have any stents, for example, that have been placed in the vasculature in their lower limbs, to see how can we keep these limbs as healthy as possible with the healing process. And definitely making a connection with the prosthetist. But that for me is just across the board with every patient who comes in with an amputation is I want to become best friends with their prosthetist because that's where it begins, the relationship there, and making sure that they have good socket fit, that they're wearing the right technology, whether they're in above the knee or below the knee or mixed for bilaterals. And if they've had, a lot of it will also depend upon what was their experience when they were a unilateral amputee. Were they walking around? Had they already learned how to use their prosthesis? Obviously, those that were walking around independently with their prosthesis as a unilateral have greater chances of walking as bilaterals. So just doing a very thorough history on the person. And then, what do they want to be able to do? What are their goals as a bilateral amputee? It takes an exorbitant amount of energy for them to walk with prosthetic devices. So it's talking to them about what this will look like for them and asking them, what are their goals? Do they want to be independent ambulators? Do they want to be wheelchair as their main source of mobility? Do they want to do a mixture of both? What is it that's going to fit into their lifestyle the best?
Yeah, and we've gotten comments in the past, just like people concerned and having interactions with the medical community and really having a bilateral amputation that some folks almost get the sense that they can't get back to life, that they can't get back to doing things, when in reality that there is so much that's out there that can be done, even though there are a lot of factors and a lot of things that we need to be taking care of. Like, there's still a lot of potential.
There is.
A lot of potential for activity. I was thinking about, as you were talking about having a good relationship with a prosthetist, I was even thinking about folks who have unilateral amputation that even if they don't have a great socket fit, they can sort of kind of deal with it in a lot of ways.
Yeah.
But as a bilateral, like that's not
No.
even on the table. Like if you're painful in both sockets,
No,
it's such a huge limitation
it
for
is.
them. Yeah.
It is. And it's, returning back to the quality of life after bilateral amputation, I'm very frank with my patients. I don't sugarcoat things because I want them to know this is what's going to be involved. And so that they know up front what it is that they're dealing with. And unfortunately, the statistics are not in their favor. I think, years ago, and again, my research statistics are not updated, but years ago when I first started out as a therapist, less than 10% of bilateral above the knee were ambulating. And that was a very stark statistic. And I would have to present this to my patients, but at the same time, I would say, those that are in that 10%, it's because they were in therapy. It's because they had a good relationship with their prosthetist. It's because they made those lifestyle changes. Yeah. So with regards to beating the odds, it's a lot about how things that are under their control, I guess is what I was trying to say. So for many of my patients, it's like, yes, it's going to be a long road and an uphill climb. But it is possible. And it's things that you can control. You can control whether or not you go to therapy for every session. You can control how you communicate with your prosthetist, and learning about the technology that you're using.
Yeah, and I think that's a good point because in some ways you're saying that there is hope. It's hard work and it's nothing simple about it.
Yeah.
But that is one of those things that it is within your power to affect some change in that category.
And lifestyle changes. I think probably my most successful bilateral was my very first one. And he was, prior to his amputation, he was maybe 5 feet 4 inches, and he was almost 300 pounds. He was a very, very large man. He got pinned between two cars and a very short above the knee and a long knee disarticulation on the other side. And this was before the microprocessor knees were available. So the odds against him were, and we put him on a program and he lost 60 pounds and we started him with stubbies and we got him going. He had everything stacked against him.
Yeah.
But it was just a wonderful example of when he worked hard. He went to the nutritionist. He stuck to his diet plan. He stuck to his exercise plan. The prosthetist and I were constantly talking with him. So it's possible. Very possible.
Yeah, and even just as you're talking about these other professions, that it's not just a rehab thing. There are this whole spectrum of people working together to make it happen. So
absolutely.
Yeah. Let's move on and talk a little bit about balance, kind of like that initial, like we're fit with prosthetics and we're up and standing. How would you say that things are different for folks who have bilateral amputations as soon as they're getting up on their feet and trying to learn that aspect of balance?
Well, from the patient standpoint, again, I'm not an amputee myself, so I cannot directly relate to my patients. But the best analogy I can think of is if I were to put on a pair of 6 feet stilts on both of my legs and somebody were to tell me to stand up, that would be just the initial reaction. From a clinician standpoint, from my standpoint, everybody's completely different. I've had some, especially with my bilateral below the knees, that they do marvelously. You stand them up for the first time in the parallel bars and just do the very simple, the bread and butter foundation exercises that we do as physical therapists. And I think when we present it in the small bite-sized pieces like that, they can progress quite nicely and in almost similar protocols to my unilateral amputees. Usually what I try to figure out as a clinician is, okay, which leg is their stronger leg? Because they're always going to, even if they have the same length or almost same length amputations, there's going to be one leg that's always a little bit stronger than the other. So I might, in the starting, exercises, I might utilize that stronger leg for the sit to stand, for taking those first couple of steps and just helping them, giving them that advantage there.
Yeah, that's a good point in identifying which side is more comfortable. Because in addition to strength, I feel like you usually have one side that you feel more confident in terms of balance as well. Particularly if they didn't have the amputations at the same time.
Right. And it's so that they can get that confidence in themselves of saying, okay, this leg, I can kind of depend upon it a little more so I can try out new things, new movements with this leg and figure it out first here and then translate it to the second leg. But yes, and then I was thinking back to my protocols and I'm like, a lot of my protocols are very similar. in how I progress my patients. And part of it mainly is because I expect my patients to have good balance, even as bilateral amputees. It just takes a little longer.
That's true. That's very true. Yeah. Do you feel like there's a difference in terms of balance when somebody has like differences between the two sides? Like say one side's above and one side's below knee?
Yes, absolutely. And when I have an above and a below the knee mix, the below the knee, it's funny. It's almost like it's not an amputation. You know, it to the person, because they have their anatomical knee, that is automatically the stronger leg. And we end up focusing so much on the above the knee side that we almost forget about the below the knee side, and it just goes along with the plan, and it just progresses nicely, which is mentally it's interesting to kind of see that in patients compared to people who have bilateral below the knee. So it's interesting to see that the below the knee side on someone who has a mix just kind of along for the ride, and it just progresses. They almost don't have to think about it as much because they're so focused on the above the knee side.
That mental energy is going to this more complex side of having
right.
to deal with
So their muscle memory a lot of times just kicks in with that below the knee side, and usually with the below the knee, it's more about focusing on how can we get that knee nice and strong and tight and stable. So a lot of strengthening on that side because it will take more of the brunt.
So let's move into things like transfers. So this is like getting up out of a chair, or like transferring from like getting out of the car, for example. Obviously, things are very different especially when you don't have prosthetics on, like getting in and out of the bathtub, or getting in and out of bed, kind of things. But let's kind of talk about some things such as getting up out of a chair first off. So we can talk about below knee and above knee separately in this category.
Yes. So for bilateral below the knee, again, I treat them very similarly to people with two anatomical legs. Because of the fact that they have both anatomical knees, it's a huge, huge advantage. And in some ways, even more so than a person who has a unilateral above the knee amputation. And this is something that amputees have expressed to me in the past, where my above the knee folks are like, man, I'd almost rather have bilateral below because I could keep both knees. So when it comes to standing up from a chair, again, determining is it weakness, is it coordination and balance, what is it that's holding them back? And I use all the similar tricks that I use for some of my other patients. So probably my favorite one is just stacking the chair up with like 6 or 7 pillows. So that they're practically standing up, and just having them do little sit to stands like that, and then gradually taking the pillow out. And they figure out the way on how to get their body to move and get themselves up. I do try my best to make sure that they're using both legs as equally as possible. That's, I think, where a lot of the wear and tear happens on those knees, in the sit to stand, especially if they're carrying a little bit of extra weight. And then, obviously with the assistive devices that we have, are they going to be using a walker, a cane, or is the goal for them to be completely independent, and utilizing it? But it's and I know you can relate to this, Will. Sometimes you have a patient come in and you're just sitting there going, how in the world am I going to get them functional in the community? And you're just thinking the car transfers and this and that. And then you just have to kind of go, okay, wait, first things first, we start here. We start here and we build a little bit upon it every week, one step at a time. And then for my bilateral above the knee, a lot of it will also depend on the componentry. Do they have microprocessor? Do they have mechanical? And this is, for me, this is my weak point as a clinician. I'm always having to go back to the prosthetist and go, okay, remind me about how this knee works again. How do they have to engage? Making sure I've got all of that knowledge up to date. So that I can teach them. And for the bilateral above, that's where I'm okay with the cheating, where I say, okay, if this is your stronger leg, let's try doing a side shift to get you up on that stronger leg and lock that knee in place first and start there. And again, elevated sit to stand. Definitely that's been my biggest help with folks, until they learn how to engage their glutes and how to really get themselves up there.
Yeah, it's a really challenging thing. And we've done a video on this, which kind of shows the challenges and how much upper body strength this one takes.
Yes, and everybody does it. It's like the getting up from the floor. Everyone finds their way on how to get it done. Yeah. I had one gentleman in there, and I just looked at him and I'm like, oh my gosh, he did some sort of pushing himself up on his arms and pop both legs at the same time in both mechanical knees and just made it happen. I'm like, Okay. So, yeah. So there's the textbook way, and then there's the, figure out what's going to work best for you and keep you safe.
Yeah, absolutely. Well, and how you're talking about like the sit to stand and having, maybe with a bilateral above knee, how they have to lock one leg out before they move it to this other one. It's not the prettiest thing, but in the end, it's what's functional, what's going to get them out there and being able to be successful in what they want to do.
Yep, absolutely.
And a little bit of trial and error.
Lots of trial and error. Yes.
Yep. Yeah, absolutely. Okay, so you and I made a video of the 3-2-1 cockroach exercise, which for those watching this, if they haven't seen this video, we'll include a link down below for it. But basically, this is a way to break up the walking cycle, and so we have a number of videos on this. But really, when we talk about this exercise, it is focused on one side specifically. So some comments that we've gotten, and I've seen this as sort of a trend, is how do you transition from focusing on that one side to now bringing in that second leg into the picture of how as a bilateral, do you tackle that, trying to bring some continuous quality to your walking? And it's not a light question.
Yeah, no, and that's a very good question. And it's one where, I use the 1-2, it's kind of become my shtick now, the 1-2-3 step cockroach, but I also do a lot in the beginning on the stance, making sure that they are able to fully weight bear. And David has a great video that you guys did on showing that with the above the knee. So for me, I'm working on both things. And when it comes to the bilateral, again, it's looking at the person and saying, okay, if this is their strong leg as a bilateral above the knee, then let me teach them how to do it with their stronger leg first, and then we switch legs. And it's a mixture, again, you have to work both the swing and the stance phase of the gait cycle, right? Because some people have said, well, you're only using the swing and they're not moving from their hip. And I go, no, we work on stance as well. We do that in a separate part. But in that regard, I just switch sides. And I take it one step at a time and just saying, okay, we did the 1-2-3 step on your right side. All right, now let's do it on your left side. And let's incorporate stance. And now let's put it all together. So it's a very similar progression. I think a lot of PTs get intimidated when they see bilateral, but it's a very similar progression as a unilateral. You're just having to do it twice.
Yeah.
To address
and
the other
I
side.
think one of the things that I've heard in comments, both in the clinic and within our comments as well, has been this idea of like people often have this stop and go walking pattern, especially as bilateral.
Yeah.
And I think once you start breaking it down and starting off with that first strong side, because usually that, if you're getting a stop and or kind of a stop and go kind of thing, like your go is usually on your good side or where you have good confidence in the balance, and then your stop is on that less confident side. So I think when we break it down and you're able to focus on like getting your stance phase and your swing phase strong on that good side, and then really focusing intently on that side that you're not quite as confident on, getting your stance control, your swing control, I think those start to meld it a little bit.
They do.
More naturally.
They do.
But ultimately, getting that continuous, it's a hard transition to get into.
It is. It's a hard transition, and I won't lie. There are some people that have a more natural talent for it, that their body gets it better. So it flows a little bit easier and they catch on. And then, interestingly enough, a lot of my neuro techniques I use on my amputees, and especially my bilaterals, especially with that whole stop and go, when we're working with stroke patients, when we're working with TBI patients who have these spastic gait patterns, how do you make it smooth? So some of the treatment techniques I used in that population, it translates nicely into the amputee population as well. Resisted gait, that's one where I find sometimes where I'm just like, okay, I've tried everything. I don't know what else to do. Let me just put my hands on their pelvis and have them push me around the clinic. And all of a sudden, things just start smoothing out.
Yeah.
Like, okay, there we go.
Again, we're coming back to this idea of it's a little bit of trial and error.
It is. It really is. And I've been doing this again for 18 plus years, and there's still new techniques that I'll pick up and learn. And each patient teaches me something new, which is what I love about what I do. Yeah.
I always tell patients that I feel like my job is the art of finding the cue that is appropriate for them. Because almost nobody is the exact same. Like I feel like I'm just throwing a handful of different cues, and it's like, that didn't work. Let's try something different.
Let's try, yeah.
And eventually you happen across something that just clicks and it makes it happen.
Yeah. And then I will say the foundational exercises, and I did not give them enough credit as a younger therapist. The stronger I build that foundation, and I'm noticing it with the simple stuff, the weight shifting, in all the different directions, those simple exercises, the more time I spend on that, I feel like the better my patients are later on in the protocols. But yeah, it's interesting. Metronome walking. That's another one with the stop and go that I found to be very helpful. And that was just accident. I'm a musician. You are too. Yeah. And it was just one of those things where I was in the clinic and I'm like, let me try this. Yeah. It worked. So just you learn to think outside the box.
Yeah, and for those that aren't familiar with that, again, watching this, usually what we're doing with a metronome is we'll kind of estimate about what a normal step rate would be. I think it's typically around 100, 90 to 100-ish ballpark. Yeah, it's different for everybody, but somewhere in that ballpark. And basically just playing a metronome so that you have a constant beat that you have to, every single step has to land on that exact.
On that beat. Yep.
So a little bit easier for people with a music background, but most people are able to kind of catch on to it to some degree.
They are. Yeah.
Yeah. Okay, so we kind of talked about balance, some transfers, a little bit into walking. Now let's sort of get into some community issues. So like things going at like stairs, ramps, kind of a little bit of outdoor terrain. Again, they're kind of a big question here. But let's talk about stairs first. What are some considerations for stairs?
Well, it's basically the safety is the number one priority, and mobility. It's easier to use stairs than it is to use ramps. Many of my patients will say that, which is ironic because, ADA has us putting ramps all over the place. So it's what technique can I teach my patient on how to go upstairs and downstairs that's going to be efficient and hopefully not abuse their stronger side. So if I have a bilateral below the knee, for example, I really try to teach them reciprocal ascending and descending if it's possible, if they have that kind of a strength. And, some of them do, some of them don't. Some of them have to do the step 2, progression with the railing. And with the bilateral above the knee, again, that's obviously a much bigger challenge. I've seen, and for those, honestly, I love going to social media and checking out some of the videos that people are posting, because they have just different techniques on how, it's not pretty sometimes, it's a lot of times, but just how do they make it happen? How do they make it happen? I remember I was chatting with one physical therapist, and his family's from Russia, and his grandfather worked for the KGB, so he had a very exciting lifestyle, lost both of his legs above the knee around Second World War, and he lived in a second floor apartment in Russia. Which in Russia, there's no such thing as any accommodations.
No.
And these were wooden sockets. And he said, my grandfather figured out, as an above the knee, bilateral above the knee, how to get up and down stairs. So that's kind of what I think about whenever I'm just like, I think back to that story and I'm like, okay, if this gentleman figured it out, this tough Russian bird figured it out, we're going to figure out some way to make it happen. Yeah. No shame in rails. That's the other thing. People almost always think that they have to be able to do things without rails. And I'm like, I use rails all the time. Why wouldn't I expect you to use rails and looking down and, those kind of common sense things that a lot of times people think, I should be able to do this without looking down. I should be able to do this without using a rail. No. Look down. Use your rails.
Yeah, safety is the biggest thing. It's like,
yes.
I mean, if you're trying to do something that if you're trying to tackle stairs without a rail, and if you think you can't do that, then you can't do stairs. Like, that's not the case at all. Like, you can be extremely functional, get out and do what you want to do using a rail. That's why they're there.
And it is, is it a pain? Yes, because sometimes it means that if you don't have stairs with a rail, you have to take the longer route to go find that ramp and get to where you're going. And that is something that I try to teach my patients and take them out in the real world when I can, and teach them how to figure it out. With the ramps, it's definitely, bite-sized pieces. So I'll put the person right at the end of the ramp so that they just have to take that one step to get to the end of the ramp, just so that they can figure out how to do it and feel comfortable with it. And then, I'll just back them up 2 steps and say, okay, now do a second step, and then slowly back them up the ramp. And that's honestly been my super fancy way of teaching folks how to do it.
Yeah, that's a great way, and less intimidating that way, because it's, like bite-sized pieces.
Bite-sized, and it takes the fear out of it, because it's scary. Very scary. And also as the PT, I'm like, okay, yeah, we still got to work on your quad strength right there. We need to go back and address that.
Yeah, yep. But I think, and there's even like simpler ways. I mean, again, it's much in the same way, like, potentially having to use a rail with stairs, like on ramps. It's like, there may be times where you just have to sidestep.
Yes.
And that's okay. Again, if you're getting out there and you're functioning, you're doing it, like, and again, it doesn't have to look super pretty as long as it works.
Yep. And then just with a lot of my patients, especially those who are bilateral above, it's just planning ahead. Just knowing where it is that you're going and what you're going to have to negotiate, and just having a plan. And it's a pain in the neck, especially when you're first getting back out into the community, to have to think so much about, where you're going and how you're going to manage to get from point A to point B. But I find people are more successful in getting back out there in the community when they have a plan. And I think as therapists, we need to figure out ways to get out in the community with our patients. With the nature of my practice, I'm able to actually physically go with my patient to the grocery store, to the mall, to these places, and just help them figure out a path on, and I think that's something that as therapists, we should be able to do that a lot more.
Yeah. Awesome. Any other thoughts about, as far as like getting out into the community, like maybe on level surfaces, that kind of thing?
Probably with regard to assistive devices. And this is something that for me as a therapist, again, 20 years ago when I started out in the career, I'm like, no, I want my patients walking everywhere and just realizing, okay, for my bilateral, they want to be out and active in the community. So that could mean that they're depending on a wheelchair for part of that. And if that's what gives them more independence and more involvement in the community and more involvement in their life activities, then do it. And not seeing that as a failure, not seeing that as, well, we didn't do our job well enough as PTs. So for example, my very first patient actually, when I opened up my clinic 3 years ago, he was an above and a below mixed. And he and his wife work a food truck. And he said, I want to get back to providing for my family. So he knew how to carry a tray with both hands and figured out how to do it. We taught him how to do it, but he just said, realistically speaking, it's exhausting for me. So, within his home, he used his loft strand crutches. When he was out in the community, he would use his wheelchair. At work, it was a mixture of both. And he figured out a way to participate in everything in his life, and not have to, so that'd probably be the biggest thing I say for my bilateral folks is figure out how you can get yourself back to your life full time.
Yeah, absolutely. That's excellent thoughts there. So I just wanted to kind of wrap up with just some general thoughts overall. If there's any last things, some things I like to say is just that for folks dealing with bilateral amputations, it's a hard process. I often hear from folks that like they think people who have only one prosthetic limb that they're cheating because they have a cheat leg.
They don't have street cred. They don't have enough street cred. Yeah.
I know, right? But yeah, and it is really an uphill journey, but it is one of those things like you were mentioning earlier, Cosi, that it's one of those things that you have the power to make a difference in order to make it better, to get out there, to live your life, and to do things that you want to do. And it may not always look pretty, it may not be simple, but there's ways to do things and ways to move forward all the time. So, any other thoughts from you?
No, that's basically it. Is there's no shortcuts. There are no shortcuts. And my best success stories have been with bilateral, because they know they have to work that much harder and that they have to invest that much more work. Whether it's changing their lifestyle, diet habits to lose the weight so that they can use the prosthetic devices, whether it's learning about the community and finding out about all their resources in the community to help them get some of these prosthetic devices that they need, and having to travel to find the right specialists who can help them out. But the ball is in their court. The ball is in their court to make it happen.
Yeah. Excellent. Well, yeah, thank you so much, Cosi, for tuning into for this and helping out with this video.
Pleasure.
For those watching, if you haven't seen already, we've got a whole series of prosthetic training videos. It's a couple hours of videos, so maybe take it in little bites. Really focusing on sort of those earlier exercises that'll kind of helps really set you up for the latter part. Always we recommend working with a physical therapist, working with your prosthetist directly, because those are always going to be your best resource. But these videos could be resources for them, can be extra resources, extra exercises for you to be able to work on yourself. And I cannot encourage you enough to connect with Cosi through Cosi Talks. They can catch her weekly, if you can tell us about that, Cosi.
Yep, every Wednesday night, 8:30 p.m. Eastern Standard Time. On my Facebook page, it's all under Cosi Talks. You can find me on my YouTube channel under Cosi Talks and Instagram, and I have a website that, guess what, guys? CosiTalks.com. I know, very original. So you can send me all of your questions there. I answer all the questions, and if I don't know the answer, I will find it for you.
Yeah, awesome. Thanks so much, Cosi.
My pleasure. Thank you, Will.